Hello and welcome everyone. My name is Matt Shepard and I'll be your moderator for today's review of the 2023 Medicare Annual Enrollment Period. Our presenters today are Center for Medicare Advocacy Associate Directors David Lipschitz and Kathy Holt, Senior Policy Attorney Kata Cortez, and we're pleased to be joined by Tatiana Fasciu from the California Health Advocates Senior Medicare Patrol, which is sponsoring today's program to discuss patterns that they saw this year as well. The Senior Medicare Patrol, as you're going to hear more about later, helps Medicare and Medicaid beneficiaries avoid, detect, and report healthcare fraud to protect beneficiaries and help preserve the integrity of the Medicare and Medicaid programs, something of great import during the annual enrollment period. And of course, the Center for Medicare Advocacy, as many of you probably know, is a national nonprofit law organization that works to advance access to comprehensive Medicare coverage, health equity, and quality health care for older people and people with disabilities by providing exceptional legal analysis, education, and advocacy. Center's work includes legal assistance, advocacy, education, analysis, policy initiatives, and litigation of importance to Medicare beneficiaries nationwide, all of which is based on the experiences of the real people who contact the center every day. We once again thank California Health Advocates and the Senior Medicare Patrol for sponsoring today's presentation, which is going to be hopefully quite full of information about the recent enrollment period. Despite that fullness, however, I have to take a few minutes of time to do a little bit of housekeeping. If you can hear me, great. Use the information in the email you received after registering to successfully log in today. And you have good quality working speakers on your computer, I hope. Our audio quality is always going to be at the whim of your hardware and internet connection. We all know this very well by now. If you are using that computer audio, be aware that if you have issues, we do have a telephone dial-in that you can use. You can call into the number that was provided on your confirmation email, and that number also appears in the audio tab on the control panel that should be at the right of your screen. A little bit more about that control panel, although I'm sure many of you are familiar with this by now. A couple key features are the little orange arrow that will let you hide the panel so it's not in your way. A little square that'll let you watch our presentation in full screen view. And please note, for the bulk of the presentation, we're going to keep attendees muted. When we have time to open things up for discussion, I'm going to ask everyone, could you please type just a sentence or two on what you'd like to bring up and discuss in the questions section of the control panel, so I can take a look at it and then call on you and unmute you. If at that point, when I try to unmute you, you still are muted, that means that you are self-muted, and you're going to have to give one click on the little microphone that's on your control panel. So be aware of that little microphone picture as well. I want to thank everyone again for attending, and I will now hand things over to David Lipschitz to get us started in earnest. David.
Thank you, Matt, and thanks to all of you for attending today. In other webinars and in other settings, we have spent a good deal of time talking about access to care issues impacting individuals in traditional original Medicare, as well as problems faced by those enrolled in Medicare Advantage plans, including such issues as prior authorization and limited provider networks. Some of that material, if you're interested, is linked in resources at the end of these slides and otherwise available on our website. Our purpose today, though, is to talk about the process of selling, marketing, and advertising of Medicare Advantage and Part D plans, particularly during the recent annual coordinated election period, also known as the annual election period, or AEP, also known as open enrollment, the time of year when Medicare beneficiaries can make choices to their Medicare Advantage and Part D coverage for the following year. Every fall, there's an advertising onslaught and selling spree targeting beneficiaries. In response to a significant increase in reports of marketing misconduct, the Medicare program has acted, as we will discuss. The Centers for Medicare and Medicaid Services, the Medicare regulator, also known as CMS, has stepped up oversight and released new rules related to marketing. As part of a quick overview that I'm going to briefly cover some of these new rules that apply to Medicare Advantage and Part D plans and agents and brokers. Let me be clear from the outset. It is not our intent to paint all agents and brokers with one brush. We know that there are honest, dedicated ones who serve their clients well. But unfortunately, there are far too many that are motivated more by their own financial interests than the well-being of their clients. And it is those who we will focus on. We will then hear from our partners at California Health Advocates, the California Senior Medicare Patrol Program, part of a nationwide network. They will provide their lens on the annual election period and issues that they have come across. Then we're going to turn back to you. When sending out registration for this call, we solicited your experiences and opinions. We want to hear from you. We received quite a few responses, which we will summarize for you. Kathy and Kata will do so. And then we'll open it up for more questions and comments. What did you learn? Are there any lessons for the next annual election period? We have ideas about how to fix some of the issues, but we want to hear about your ideas. So we've kind of, as far as summarizing the comments, as Kathy and Kata will walk through, kind of broke them up in different categories, as you see here: marketing, including marketing targeting individuals duly eligible for Medicare and Medicaid, agent broker conduct, Part D issues, and other issues. So, as a quick refresher, it is the annual election period, the period last fall from October 15th to December 7th that we are primarily focusing on. But just a quick reminder to everyone that we are currently in another Medicare enrollment period, that is a Medicare Advantage Open Enrollment Period, the MAOEP, which lasts through the end of March, but is only available to folks if you began the year with some type of Medicare Advantage coverage. As we have discussed elsewhere, there are unequal rights in Medicare as far as access to different coverage options. I also want to quickly remind folks that there are special enrollment periods that are triggered by different circumstances, including marketing misconduct and being duly eligible for Medicare and Medicaid. So, in 2022, CMS, the Medicare agency, reported that beneficiary complaints about Medicare Advantage marketing more than doubled between 2020 and 2021. Congressional reports and hearings conducted by the Senate Finance Committee found evidence that beneficiaries are being inundated with aggressive marketing tactics as well as false and misleading information. So, the CMS issued some new rules to try to address some of this marketing conduct that were effective as of the first day that Medicare Advantage and Part D plans could market their 2024 products, October 1st, 2023. In their written justification for this new rule, CMS reviewed complaints lodged with 1-800-Medicare and indicated that they revealed numerous complaints that beneficiaries were not aware that their current coverage would end once they were enrolled in a Medicare Advantage plan. And further, in over 80% of marketing and enrollment calls that the Medicare agency reviewed, agents and brokers failed to ask pertinent questions to help a beneficiary enroll in a plan that best meets the individual's needs. What follows is a quick overview of some, but not all, of these new marketing rules that apply to both how plans are marketed and described and certain agent and broker conduct. A full description of these new marketing rules is included in a link at the end of these slides to a special report that we issued in May of last year. So, with respect to ads, these new rules include rules aimed at curbing misleading use of the Medicare name, logo, products, or information issued by the federal government, as well as limits on marketing benefits in an area where the benefits are not, in fact, available. One significant change that came out of these new marketing rules is reinstating a distinction between education and marketing events. In recent years, the lines between these two types of events have been blurred. Educational events are essentially events where beneficiaries come to find out more general information about their coverage options. They're not supposed to be marketed to, and they're not to be sold particular plans or a type of plan. That's opposed to marketing, where it is very clear that the intent of the session is to try to sell you a product, to convince you to enroll in something. In educational events, one cannot be sold products or sales appointments cannot be set up. A rule change in 2018 allowed such events to merge into one another, setting up people who are just seeking general information for aggressive sales pitches. Thankfully, CMS reinstated the distinction between these two types of events and notes that they must be separated by time. At least 12 hours must occur between an educational event and a marketing event in the same location. In order to minimize incidents of quick, high-pressure sales, CMS is requiring a cooling off period, essentially, from when a broker first collects an information from someone, usually a business reply card, and when a sales meeting can be set up, with some exceptions towards the end of an enrollment period. CMS reiterated the existing prohibition against door-to-door contact without prior appointment. So even if you gave an agent your information about who you are, but you didn't set up a sales appointment yet, that agent is not supposed to come and knock on your door unannounced without an appointment. New rules also put a limit on how long an agent can contact you after collecting your information. It's now 12 months. CMS originally proposed 6. We thought it should be shorter than that. But bottom line, there is not an open-ended opportunity to market to you for the rest of your life just because you filled out one of those reply cards. In an effort to boost informed decision-making, there have been some additions to pre-existing rules, including one that requires and accompanies hard copy enrollment forms to plans. There's something known as the pre-enrollment checklist that has a number of elements that are supposed to be reviewed with a prospective enrollee. To that list of elements was added the effect that an individual's enrollment choice will have on their current coverage. In other words, if you're in traditional Medicare and you choose to enroll in an MA plan, how is that going to change your access to care? Do you have a current product that you will lose if you enroll in another type of coverage? The hope is that this will lead to better informed decision-making. And in that line, there's a new requirement in addition to the pre-enrollment checklist that is essentially a list of required elements that agents and brokers must discuss with beneficiaries prior to enrollment in a Medicare Advantage or Part D plan. This list includes some of the essential issues that people must consider in order to make an informed choice, including questions, issues, or prompts that get at talking about things such as provider or pharmacy networks, out-of-pocket costs, prescription drug coverage, and other elements. Again, the hope of which is if this is followed, it will lead to better decision-making and more informed choices on the part of beneficiaries. But have these rules made a difference? These new rules that were in effect as of October 1. As Kathy will discuss in more detail, some of the feedback that we have received from you is that the TV ads might be a little bit better, print ads maybe not so much, but overall, people seem just as confused about their Medicare coverage options. What about the Medicare agency's concerted effort to do more oversight and enforcement against plans and agents and brokers? One tidbit we learned from Politico is that CMS reviewed more than 3,000 Medicare Advantage ads between May and December of last year and rejected more than 1,000 of them for not meeting the agency's rules, more than 80% of which were submitted by third-party marketing organizations, the ones that were rejected. So now we're going to turn to our colleagues at the Senior Medicare Patrol, Tatiana Facio, which is California's Senior Medicare Patrol program. After Tatiana is done, Kathy and Kata will summarize some of what we have heard from you, and then we'll open it up to hear even more. Tatiana.
Thank you, David. And yes, just tagging along what David has said and preview, I'll go over some of the actual experiences that we've had, but they are not necessarily exclusively of what's happening in California, but on a national basis. So next slide, please. All right, a little bit of what California Health Advocates is. We provide quality education for the local HICAPs, the SHIPs, the State Health Insurance Assistance Programs, but we also do a lot of advocacy and assist beneficiaries with answering their questions and potentially refer them to the local SHIP in California we called HICAP. And also our major project is the Senior Medicare Patrol. Next slide. All right, so in the area of the Senior Medicare Patrol, which is a national program funded by the Administration of Community Living, we educate Medicare beneficiaries and their family caregivers to these three basic concepts: to prevent fraud, to detect it, and to report it. And how does one prevent it is what I will tell you next in the next slide. So this is your Medicare card. Beneficiaries, whether they are enrolled in a Medicare Advantage plan or in original Medicare, they all have to have this Medicare card. That is their evidence of coverage under the Medicare program. And it is essential that Medicare beneficiaries protect that card, because if that number gets divulged to unauthorized agents, you could have a real problem with overbilling Medicare or abuse of your Medicare benefits. Next slide. So some of the current complaints, which are not only evident here now, but what has happened over the last 12 months. As David mentioned, the marketing of these plans, particularly Medicare Advantage plans. And this is an area where we like to empower all Medicare beneficiaries and their Medicare and their family caregivers to watch out. The cold calls are still happening. The television commercials targeting dual eligibles, which is something that has occurred year-round last year. Why? Because dual eligibles are able to change their coverage once a quarter. And this is where the potential marketing fraud happens. The television commercials are just now also focusing on the dual eligibles, even though we are in an open Medicare Advantage open enrollment. We've also had the billing issues. Whistleblowers are coming now to the Senior Medicare Patrol reporting that home health agencies are pressuring the billers to bill for additional services not given. Deceptive hospice enrollment. This is one of the most insidious versions of healthcare fraud, because what happens when a person is enrolled in hospice? They stop all curative measures. And it is in some of the reports that we've had, they've called or responded or were marketed on a door-to-door basis. What are your limitations? Well, I just need help with bathing or dressing, and boom, they're enrolled in hospice and they have to stop all curative measures. The Medicare phone card. Medicare is not sending anybody a new Medicare card, but this is happening nationally, where solicitors are calling Medicare beneficiaries and they're telling them that Medicare is mailing out a card, and all they need to do is verify their Medicare number. Genetic testing, that is still continuing, and we've had situations where a beneficiary who may have been just concerned about their genetic predisposition for certain conditions, and now they are being abused, or should say the Medicare system is being abused by offering these unnecessary testing scams or testing for genetic predispositions. And COVID test kits. We've had reports that Medicare beneficiaries have received 5, 7, or more COVID test kits unsolicited. We know now that the post office is sending out again COVID test kits, but these have been billed to Medicare, these COVID test kits, in an unnecessary and in a fraudulent manner. Next slide. So SMP, the Senior Medicare Patrol, wants to hear from you, just as later on we want to hear from you. We want to hear from you about what looks too good to be true in the new marketing rules that have been in effect now, but they are still being abused. Advertisements that, one, do not mention a specific plan or use the Medicare name or logo in a misleading way. The marketing benefits in a certain service area that may not be available where that individual is. The superlatives, we know that the best and the most are not supposed to be used, but it is still happening. Cold calls, third-party marketeers are still doing it. And when you look at your, I've even gotten those too. You look at your caller ID, it comes out as healthcare. Well, those are marketeers. And advertising and media promotion that you have seen, we want you to take a screenshot and email it to the Senior Medicare Patrol or call them. On the bottom of your screen is the local California number, and the national number is the 877-808-2468. And following, we would like to show you some examples, but we want your examples too. Next slide. This is a Humana Medicare Advantage Plan commercial that I don't watch TV very often, but somehow I did, and I saw this. This was a promotion for the dual eligible special needs plan. And I found the commercial online, which was exactly the same one that was broadcast on TV. And as you can see, it was for the annual election period of 2023, but it was broadcast originally in February of 2023. So they're repeating this commercial. So they're targeting dual eligibles and highlighting, the free rides for medical appointments and other benefits that you will, a card, and the next slide will show you. Technically, this doesn't violate the rules, but the moment people hear these additional benefits, they will call that number on the screen. And what happens there is potentially an inappropriate enrollment. Next slide. So this was another screenshot that I took from the same commercial. Up to $3,300, and that is what people hear. They want that debit card or this cash card that could be used for food or for other benefits or for other needs other than maybe over-the-counter drugs and so forth. But is this the only benefit that a dual eligible needs? Because you have all of those other ramifications about, is that provider in the network? What are the consequences to enrolling in a dual eligible special needs plan to that beneficiary's overall health? Next slide. So we have seen and continue to see, and we want you to report, how heavy is that television advertising targeting dual eligibles or targeting beneficiaries who are enrolled already in a Medicare Advantage plan, but encouraging them during this time period to change plans. So we know during open enrollment, Medicare Advantage plans were touting all these extra benefits without really focusing on, is this going to be good for you? What we've also experienced, medical groups now are promoting Medicare Advantage plan enrollment just as a way of only accepting new beneficiaries or new patients that are enrolled in a Medicare Advantage plan. Why? Probably because they're getting additional funding. Telephone enrollment during a cold call, that still has happened. When beneficiaries call the number on your screen, they may only want to know maybe about Medicare supplements. And the moment that caller gives out, and it's not supposed to, information is information. So they're not supposed to be collecting their Medicare number, but it has happened. So during this Medicare Advantage open enrollment, there is the yin yang. There is the good the bad and the ugly. And so if you're going to want to go back to original Medicare because you had a Medicare Advantage plan previously, there is a connection to, do you want a Medicare supplement, Medigap? Depending on the state that you're in, you may or may not be able to get a Medigap plan without underwriting. So it's very important for individuals to understand this. And yes, one can change Medicare Advantage plan if they missed that previous open enrollment. So it's important for those advocates on this call to really explain what are the pros and cons of enrolling in or disenrolling from a Medicare Advantage plan, or for that matter, going back to original Medicare, where they would have to also get a Medicare Part D plan. Next slide. So these are some actual examples of print media that has been mailed to beneficiaries. This one looks like it's coming from the County of Los Angeles. Los Angeles County Medicare Benefit Update. I myself have gotten a similar card, says Butte County Medicare Beneficiary. The county is not sending out anything to individuals. But again, the fine print, read the fine print because it is a marketing solicitation. Next slide. So we've had also reports of mailers that look like it's official from the government. You know, especially now when beneficiaries have received their trifold 1099 from Social Security, well, the marketeers are using that trifold modality, that example, which encourages the person to open immediately. You know, but what's happened is that in this particular one, they didn't think. It says, and I'll tell you, it says employment benefits. Well, a Medicare beneficiary in most cases may not be employed. Then another one looks like an IRS form, a T2 form. These are all ways of eliciting an opportunity for a marketeer to contact them. Next slide. And another one also. This one focused on the back and knee braces, but as you can see, they use these key words: Medicare and insurance information, claims document registered to. So these are hooks that the unsuspecting Medicare beneficiary or a family caregiver may complete and give out unnecessarily their Medicare number. Next slide. So some examples that we noticed last year, and we are empowering the callers or the participants in this website, on this webinar, to look at those print ads, see how they comport to the new regulations. This came out back in October in the Sacramento Bee. The marketing rules were already in place, but it doesn't tell you anything about the who, what, where, and when. It has this Medicare, and it makes them look very official. The next slide, on the other hand, this one did comport to the Medicare regulations. But why? Well, it is from United Healthcare. It did appear in the AARP bulletin. Well, we all know that AARP gets a lot of money by endorsing or having United Healthcare use their endorsement to promote Medicare health plans, whether they be Medicare Advantage plans, prescription drug plans, or Medicare supplements. But they did pretty much comport to the new marketing regulations for printing. The next slide. So we encourage our beneficiaries to go to the real thing, the Medicare.gov, if they're really searching for an alternative now during the Medicare Advantage open enrollment. And before, of course, they did it. They just responded to television commercials or some other type of high pressure tactics. Next slide. So to detect, you keep track of your medical appointments. Use a journal or a calendar. Look at the Medicare summary notice, which is that statement for those who are in fee-for-service, to see whether that appointment or that medical care is exactly what was billed under the summary notice. Or if you're in a Medicare Advantage plan or in a prescription drug plan, look at that explanation of benefits to see if they match what you got. And then check the statements for services that were either not rendered, are different, because upcoding has happened a lot. We have had so many reports of hospice upcoding or inappropriate upcoding just so that Medicare or the Medicare Advantage plan pays the provider a little bit more money. Double charging or charges for services that were not ordered by the primary care physician. Next slide, please. So what do you look out for? Look for that Medicare summary notice, explanation of benefits, and compare that to the journal maybe, or your calendar, and report. If anything doesn't look right, call the Medicare, the Senior Medicare Patrol Project. Next slide. And you report. So we covered detect, prevent, now report. And here's the national toll-free number, 877-802-2468, and in California, 855-613-7080. Next slide. And all Senior Medicare Patrol projects around the country have access to flyers that can be posted at senior centers, at senior apartment complexes, or anywhere where Medicare beneficiaries congregate. But watch out for anything that looks too good to be true under the cold calls, the TV ads, the mail, and also the local ship can help. In California, they're called HICAP. So just watch out for if it's too good to be true. Next slide. And here are some of those fraud alerts that are available not only to the ships, the local Senior Medicare Patrol, but if they come in several languages, depending on the area, one may want to order a supply in a language or languages that are prevalent in your local area. Next slide, please. So California Health Advocates also in California wants to offer to you to subscribe to our newsletters, because we will send you fraud alerts and so forth. Next slide. And so these additional resources, if anybody wants to report some inappropriate marketing, the local state departments of insurance has on their website a complaint form, because licensed insurance agents, or I should say insurance agents, must be licensed in the state that they're marketing. So if a person gets a cold call or they're talking to an agent, ask for that agent's license number for that particular state, because individuals could file complaints against that insurance agent for behavior or anything like that that would be inappropriate. And of course, the local state health insurance assistance program, SHIP. And I've shown the hyperlink to find your local one. And I thank you for the opportunity for giving you a little snapshot in what's happening with respect to fraud. David?
Thank you very much, Tatiana, for all that important information, including stuff to look out for with respect to Medicare marketing.
Thank you.
As we noted at the outset, we solicited your feedback on what you experienced during the recent annual election period. And we're going to summarize some of the common themes that you reported back, much of which comports with what we too have witnessed. Were there any lessons learned any suggested fixes to the issues that you encountered. We certainly have ideas of our own, but we'd love to hear yours. And we can incorporate what you tell us into our ongoing advocacy efforts to make the program work better for Medicare beneficiaries. So now I'm going to turn the reins over to Kathy.
Oh, thank you, David. I appreciate that. So we received just shy of 100 responses, and we're very grateful and thankful for the individuals who responded. And as David mentioned, we've grouped this information into similar topics. So you'll notice, for instance, on this slide at the third bullet down, there's a little asterisk on that bullet. Essentially, where you see an asterisk in this section, those are particularly mentionable because they received so many comments on that particular issue. So as we go through this and look at these topics, you'll see that. I want to give a particular shout out to so many people who spoke to me, but in particular, Mary from Florida, Rodrigo from Connecticut, Sophie from California, for their additional information. I tried to speak to as many people as I could to get additional information and to ferret out a little more information. As we go forward in looking at this, I will tell a few of those stories as well to give you some more information, but here we are looking at these topics. So the first one is searching for reliable information. Some of the information that we received is that the process of the annual enrollment period is increasingly complex and difficult to navigate. There are more scams and there is more distrust among the public. As you see when we'll go forward, none of this is news to any of us, but it certainly reinforces what we've thought, what we think, what we see, and helps us to understand that we need to do something about these problems. It's hard to compare many Medicare Advantage plans. There's no full picture of what's included in Medicare Advantage, as many of you know, and there's a lot of misinformation. Again, a highly discussed topic was the Plan Finder tool and 1-800-Medicare not always providing correct information. The process itself is stressful. There are numerous MA plans, and as we know, there are many changes that happen during every annual enrollment period. Having said that, there were several comments from individuals, and again, realizing that the people that responded, the almost 100 people that responded to our request for feedback, it showed us that there were SHIP counselors, SMP folks, beneficiaries who were approaching this for the first time, or beneficiaries who were very familiar with the annual process. A number of people mentioned that there were no problems because they rolled over into the same plan, and it was easy because there were no changes. So it'll be interesting to dig further into the individuals who gave us that information, because it could be for various reasons. One could be that they're in traditional Medicare and it was easy because we know that traditional Medicare rarely changes. And so for that information, that could have been where people got their sense of ease about Medicare and the Medicare that they're receiving. Although that's not always true, as we know, plans change, prescription drug plans change, as well as Medicare Advantage plans and the information for that. So one of our deeper dives is going to be to determine if someone thinks there are no problems, they rolled over into the same plan, but they didn't really look to see if there were changes in those plans. They will be surprised down the road if they think that something is covered, but it changed in the last annual enrollment period. So more work to do as we go through each of these. Next slide, please. Another topic is observations on coverage and cost. A number of individuals said that there's higher interest in choosing plans because of flex cards, over-the-counter coverage, and other extras that Tatiana just talked about. Also, many people are stuck in Medicare Advantage because Medigap supplements or Medicare supplements are too expensive or they're not available. We also noted that there are more individuals, more and more, who are considering dropping Medigap plans, but staying in traditional Medicare without a supplement plan. Costs are too high. Many are not able to pay for certainly what they want, but also for what they have. Medicare Advantage plans have more co-insurance and less co-pays, which is interesting, right? We know that co-insurance is a percentage, co-pays is a flat amount. If you have more expensive services with a co-insurance, you are going to pay more for your share of those services. Cost options in the Plan Finder tool aren't always accurate. You'll see again that there are some themes that are happening here. Next slide, please. So getting help choosing. This was a category where it was mostly about SHIP counselors showing us what they experienced, but also people who were experiencing trying to get help from SHIP counselors. So some of those comments where the public doesn't know about SHIP counselors. Again, generally, obviously, there's a lot of calls that are coming into the SHIP, but relatively speaking, with the number of Medicare beneficiaries, there's not a great amount of information or knowledge of the public about SHIP counselors. And also, in that same vein, SHIP counselors are not readily available. That goes with the territory. Volunteers are very busy with a high volume of calls. Some folks said that SHIPs didn't respond to calls. So as an alternative, those individuals called a broker and noted that those brokers were also not charging for their services. Of course, we know that brokers get their commissions from the work that they do. And as David mentioned, shout out to the really good actors who are really trying to help individuals. Those are the folks that follow the rules, and we know that there are good brokers out there. The more complex Medicare becomes, the more time is needed to spend with clients. So again, this goes to the volume of services and the complexity of the topics that SHIP counselors are dealing with. The need to help people who don't have computer access. We know that there are a lot of places where difficulty communicating and getting access. There were also a number of comments where there was a, if you could wish something, you would wish that people would not wait till the last minute to seek help. I imagine being a SHIP counselor the first week of December is not an easy feat at all. Next slide, please. So this topic is about medications. Lots of comments about access, coverage, and cost. The fewer benchmark plans for low income subsidy. Almost as soon as open enrollment started, we started to hear about the issues with the benchmark plans. Some areas only have one plan, and there was a lot of comment about how having limited access to benchmark plans was forcing people into choosing Medicare Advantage prescription drug plans. There are fewer prescription drug plans overall. In addition to those benchmark plans declining, also PDP plans are declining. The Plan Finder tool, as mentioned earlier, is frustrating, and not all the drugs or pricing is available. Calls to prescription drug plan companies resulted in frustrating long waits. Some premium increases were significant, but zero premium plans were popular. Again, we caution people, make sure that you're not purchasing on premium alone. Make sure that you're looking at whether your drugs are covered and then what the payment for those drugs would look like. More formularies are narrowing, also creating hardships. Brand name drugs are becoming more costly, and a lack of available information about what happens to medications when individuals enter long-term care. So as I mentioned, with the breadth of comments that we received, some of them were very specific, some of them were about issues that we weren't familiar with. So thank you again for providing even these kind of nuanced issues that are really important, especially if you're someone who's entering long-term care. Next slide, please. Advertising and marketing. So the comments around this was marketing is not good for mature folks. It's confusing. And the entire process of the annual election period is frustrating and frightening. People who are covered by group retiree plans, federal employee health benefits, TRICARE for life, are confused by ads, want to sign up for the $0 premium plans where they're already kind of committed into a different option. So you see, there was a lot of comments about this. I spoke with Mary in Florida, who had entered a commissary on a military base and found a Medicare Advantage display table with some young men, and they indicated to individuals who were walking past them, who typically have, if they're an older shopper in the commissary, had TRICARE for life. Which is a program for people over the age of 65 who had been in the military. So these individuals were saying that they could help these veterans to save money. When our friend Mary challenged them, they said they were only providing education. And it turns out from the business card of one of the individuals, he was only licensed in Florida to sell Humana plans. They really were selling plans. They weren't just educating people. And it turns out that this group was out of Utah. They had a website that said something like veterans.healthcare.com. And it was just, the website was just one page. It no longer exists. And it's unclear how they got onto the base, into the commissary. But my point being that, so what Mary did was everything that Mary should have done. She reported it up through her ship as a ship volunteer herself. She investigated. She really looked at, if you see something, say something. That was what Mary did, and reported it through to CMS, to the Humana plan. It was reported, and importantly, because of the licensing, as Tatiana mentioned, in the state to the insurance department of the state of Florida, who is now investigating the problem. So it's important. One of the questions we got from someone in this process was, where do we report things? Who do we report them to? And the answer to that question is report to all of the places that I've just mentioned. Because it's important that everybody understand where the problem is, and it's not siloed into one of those operational entities or another. In addition to that, we see that there's excessive unsolicited non-compliant calls. CMS marketing changes have not necessarily worked. People continue to be bombarded. The calls that people are getting, or the contacts that they're getting, are bolder and more aggressive. Comments from many individuals about how it's a nightmare. Why are Medicare dollars allowed to be spent on advertising? There are not as many misleading claims of benefits. It's better than in the past few years. So some people are experiencing the effect of CMS rules and thinking that indeed things are better. And I think many people have mentioned that the TV ads are better, the commercials are better, but the mailings are worse and extremely misleading. Next slide, please. So when it comes to actually getting health care, some individuals indicated that the primary care practitioner participation information is increasingly difficult to locate. There are many new MA plans in rural areas, but access to local care is limited in those networks, and networks are not adequate. And some comments referred to the fact that while some practitioners may be covered, the facilities where they practice are not covered. Next slide, please. So there were some recommendations that were offered through the process. Let's better understand what Part C doesn't cover in practice. We know that Part C plans, Medicare Advantage plans, are supposed to cover everything that Medicare Parts A and B offer, as well as the additional services. But let's make sure that they are offering those services and in the quantity that's necessary for individuals who are eligible for Medicare. Some recommendations were that Medicare should operate more like the Affordable Care Act marketplace exchanges, that the annual election period should be extended for prescription drug plans through the first quarter, similar to the Medicare Advantage open enrollment period. And this reason stated was because there's just not enough time in the annual enrollment period to process all the requests that are necessary for PDP plans. CMS should create and promote a centralized contact place for complaints and concerns. You know, we say to people, oh, call everybody, call the insurance department, call the CMS, call the plan, make sure that everybody gets reports and everybody gets the same information. That's really clunky to do. So is there a place where those complaints and concerns can happen? And not only that, but can they happen, can something happen more quickly? So that, you know, it's lovely that Mary walked through the commissary and was able to stop these people from doing what they were doing, but how many more people have to be harmed if they didn't get up and walk away? So that's a question. Let's further encourage beneficiaries to plan ahead. Don't wait until the end of the annual enrollment period to explore and confirm choices. I did want to just also indicate, Sophie in California wrote, in our local service area, a major medical provider terminated its contracts with all Medicare Advantage plans, causing 32,000 patients in those plans to have to change their coverage, either to change to traditional Medicare, stay in a Medicare Advantage HMO plan and lose some of their providers, or get a Medicare Advantage PPO and pay high out-of-network rates. Many beneficiaries could not afford the Medigap and ended up staying in Medicare Advantage and changing their providers. The reasons stated for making the change were low Medicare Advantage payment rates and Medicare Advantage payment denials. So some of the recommendations have to do with, let's look at why providers are more and more, as we go forward, deciding that they don't want to participate in Medicare Advantage plans and how that's hurting beneficiaries as well. So this all goes to the recommendations. Next slide. Excuse me. Finally, the words and the sentiments that were used most frequently, excuse me, confusing, complicated, misleading, and stressful. So I will pass it over to Kata.
Kathy, thank you so much. So in December, our colleague at Disability Rights Connecticut, Sheldon Taubman, called to our attention a misleading Medicare Advantage advertisement in the Hartford Courant that had appeared over a 2-week period during the annual enrollment period in full or half-page ads. On December 7th, the Center for Medicare Advocacy, along with Disability Rights Connecticut and the National Health Law Program and the National Disability Rights Network, sent a letter to CMS and the FTC urging the agencies to address the ongoing misleading advertising in Connecticut by UnitedHealthcare's Medicare Advantage plan that was directed at duals. The letter called for both immediate corrective action against the plan and for a nationwide investigation of similar misleading advertising. The letter is linked in the slide. Oh, sorry, David, it's the previous slide. We asked for a national investigation because we know that if this is happening in a few states, it must be more widespread. Next, I'll quickly walk through this ad and why it's misleading. Next slide, please. The ads were clearly targeted at Connecticut Medicare and Medicaid enrollees. It explicitly stated, eligible for Medicare and Medicaid, you could get more with UnitedHealthcare. And then it continued, if you're eligible for Medicare and Medicaid, take advantage of your chance to get more benefits than original Medicare, all for a $0 monthly premium. And then it listed those supposed extra healthcare benefits, stating you would get $130 credit every month to pay for healthy food, over-the-counter products and utility bills, $2,500 allowance for covered preventive and comprehensive dental services, $0 copay for 24 one-way rides to and from doctor's visits or the pharmacy, and $0 copay for routine eye exams and lenses, plus $300 allowance for eyewear. As experts in Connecticut Medicaid, Disability Rights Connecticut highlighted just how misleading this ad was, and so we outlined this in our letter. In Connecticut, all individuals with full benefit Medicaid are entitled to unlimited dental service without hard financial caps. They're entitled to routine eye examinations and a new pair of eyeglasses at least once every 2 years, as well as unlimited non-emergency medical transportation to get to and from any medical appointments covered under the Medicaid program or jointly under Medicare and Medicaid. There are also no copays in the Connecticut Medicaid program for these or any other healthcare services, and there are no premiums for Medicaid enrollees in Connecticut, including under Husky C, which is the program in Connecticut that all the duals are assigned to. And Medicare premiums and copays are covered under the Medicare Savings Program. So the benefits in the ad that are listed as extra, actually Connecticut Medicaid enrollees are already entitled to under Medicaid. The only exception is the potential for the $130 monthly credit for healthy food, over-the-counter products, and utilities. But as Tatiana discussed, we don't really know how that works in practice. Are there limits or exclusions for that? And even if the enrollee is eligible to use that full $130 credit monthly, it would not make up for all that a beneficiary could lose if they join an MA plan over traditional Medicare. As we know, enrollment in the MA plan could lead to disruptions in care, denials of care due to new prior authorization requirements, and certainly a more limited network of providers under the MA plan when compared to traditional Medicare. Nowhere does this ad address those trade-offs. As we stated in our letter, we know that, quote, misleading advertising is intended to induce and has induced thousands, if not tens of thousands of older adults and disabled low-income individuals we are charged with representing to sign up for United Healthcare's plan, having been led to believe this means they get extra healthcare benefits. And because the advertisement does not mention either the limited network or the restrictive prior authorization rules applicable under United Healthcare's plan compared with traditional Medicare plus Medicaid, these individuals have no idea they are giving up something valuable, end quote. Our letter and this ad also caught the attention of Senator Blumenthal in Connecticut. He has also called for an investigation into the ads and said at a press conference that federal authorities should impose substantial penalties for this deceptive and misleading advertising. We will continue our advocacy on this issue and ask that all of you also keep a close eye on these advertisements and keep informing us as well. I know we're asking you to alert a lot of people, but we would just like to keep tabs on it just to see where we can assist with our advocacy as well. We hope that alerting CMS to these will lead to stronger action on their part. And we really urge you to take a look at in your state, because we know that you are experts in Medicaid in your specific states. So you're really best suited to call out these misleading advertisements in this methodical manner like we did in this letter, where you outline exactly where the ads claims are false. This would be particularly useful to share with CMS, especially as they are certain to get pushback from the plans. As Kathy said earlier, we want to thank everyone who responded to our previous request for our experiences during the annual enrollment period, and we thank you for your ground assistance to beneficiaries and for sharing with us what's happening in your state. I was going to walk through on the next slide a couple additional examples, but given the time that we have, Matt, should we go to questions instead of walking through these, or should I quickly walk through them? Do you have questions in the queue?
Even if we go to questions, we are probably going to go over, given that there's 2 minutes. So you may as well whip through your examples.
Okay, I will quickly do that then. So one commenter from California said that last November, she helped a beneficiary with full scope Medi-Cal who was newly enrolled in Medicare. And because of a phone conversation with a broker or salesperson, they recently enrolled in a Humana MAPD. The client had full scope LIS and used county physicians who she liked and trusted and wanted to keep. The MA plan offered her nothing more, cost her a monthly premium, and restricted her choices. The commenter continued that it was really difficult for the client to understand this, and it didn't help that they were getting correspondence and membership cards and everything from Humana. And she was very confused. The commenter said that she didn't trust that she could or should disenroll from the MA plan and still have all the health coverage she needed. She ended up choosing a standalone PDP and disenrolled from the MA plan. But I think it's really telling that the beneficiary didn't trust that she could or should disenroll. I think that's particularly important because we know that plans often say, well, if the plan isn't meeting the beneficiary's need, they can just disenroll. And we know that in reality, people are very hesitant to make a change like that. They're concerned that they won't have healthcare coverage. So I think this example really speaks to that concern. Kathy mentioned some LIS issues. Someone from Wisconsin also told us that when they do a plan finder search, it doesn't show if you're losing LIS for the next year. So in order to get correct cost estimates, you have to run a general plan finder and enter in all the medications. They were pointing out that this is really time consuming for SHIP counselors to do this. And also the commenter was concerned that a beneficiary might not read the letter from SSA that says they're losing their LIS and not know that they need to do a general plan finder. Was just generally concerned what would happen to someone who didn't have access to the SHIP and didn't have help and just had to use 1-800 Medicare or was just trying to figure it out on their own. So just the complexity of all of it. So I just want to echo again Kathy's thanks to everyone for your responses. I only highlighted a couple of them, but we review all of them and they really inform our policy advocacy. So we appreciate everyone taking the time to send them to us. And with that, I'll turn it over to David.
Thank you, Kathy, and thank you, Kata. As both Kathy and Kata mentioned, we heard from many of you and did our best to try to find some through lines and summarize much of what we heard. But clearly, we didn't capture anything. What did we miss? As Matt noted, we are at time, but we're happy to go a few minutes over and hear from some of you, including comments or questions posted in the chat. If we run out of time and you still want to share with us on the following slide here, there's an email address to send your comments to. And as Kata noted, we will read them, we pay attention, and we factor them into our advocacy work. So Matt, I don't know if you're able to identify any particular issues that might have been raised that had a higher volume of folks commenting, or any particularly pertinent things you'd like to start with.
Yeah, thanks, David. We did have a couple themes. One that came up, including from one of those good guy agents that you mentioned early on in the presentation, Paul and Joan, who's a SHIP counselor, I believe, both said that the only reliable network information comes from the actual provider, but the complication there is that you have to know your specific plan, because the provider might just say, sure, we take Aetna, but they may not take your exact Aetna plan. So even with the best source, you've got to be really careful. And then we had a couple questions on enforcement. For example, how do we get CMS to monitor these violations from bad players? I hear virtually nothing about enforcement or any penalties being assessed.
That is an issue that many of us, I think, have been grappling with. There is a system for corrective action plans by CMS, and there is a portion on their website where they post corrective action plans that are taken. And CMS does have some authority to force plans to engage in efforts to fix faults that they find. It could include civil monetary penalties, include a freeze on enrollment, and it could include all the way up to terminating a contract, which we rarely see. I think one way to sidestep the question, in part, is to ask a rhetorical question in return, and that is, now that we have over 50% of all Medicare beneficiaries in Medicare Advantage plans, has the Medicare agency's resources been allocated appropriately or accordingly in order to appropriately monitor all of that? And maybe I will answer the rhetorical question by saying it's not likely. So we need more funds, I think, for those who are enforcing it. We need more flexibility on the part of the regulator to impose higher sanctions. And we need to minimize the influence that a lot of the powerful actors have. The large insurance companies had a lot of leverage and push back when they are being punished. So there are a range of reasons, but I think overall we certainly agree. We need to see more tangible action and consequences that amount to more than just the cost of doing business in order to actually deter bad behavior. I don't know if the rest of you have anything you'd like to add to that.
Yeah, I'd just like to add that I think getting Congress involved also puts additional pressure on CMS. So we appreciate Senator Blumenthal's efforts and other members who really also come out and say this is false, this is deceptive. CMS, take action. That's really helpful.
And if I could add to that, you know, the star rating, the impact of complaints against plans does have an ultimate impact on the star rating of, you know, on boots on the ground. We don't recommend that you choose a plan based on their star rating, although it could help. But the local CMS, Center for Medicare and Medicaid Services regional offices could accept complaints also regarding inappropriate marketing and those type of concerns, and it could go directly to the CMS plan manager that is ultimately going to be reviewing the contracts for the next year. So I think that the more we bombard the regulatory bodies with these concerns, hopefully we'll see some action. And definitely we are in an election year, so those difficult questions and comments need to be brought up to those candidates.
Thank you, Tatiana. Any other through lines of questions or comments, Matt?
A lot of comments, a lot of stories to go along with the stories that Kathy and Kata shared. A quote unquote great one from Joan here. Some clients reported that they got harassing calls telling them that if they didn't sign up to renew their plan, the plan would be canceled. Lots of high pressure calls from many companies, and counselors had to reassure these people that if they did nothing, their plan was going to continue.
We had, you know,
story after story like that.
Sorry, Matt, one of those stories before soliciting comments for this webinar, we did hear from a SHIP counselor in Pennsylvania who indicated that she had heard from a number of clients who were contacted by agents who sold them a plan in the previous year, but when the individual chose to enroll in a different plan, that same agent called them and tried to convince them to switch back because they were going to lose their renewal commissions. Purely motivated by financial interest. Sorry to interrupt, Matt. Go ahead.
No problem, no problem. We did have a request to put that email address back up for people who wanted to submit comments or questions. We should warn you, not every specific inquiry will receive a response. We really want to gather information here. And speaking of email addresses, Tatiana, someone asked if there was an email address to send copies of ads and other outreach to. They just saw the phone number there.
Looks like you're on mute, Tatiana.
Sorry. Okay. Yes, on California Health Advocates website, and that would be cahealthadvocates.org. There is a link to send information to us. But I'll also, you know, if you wanted to, I'll give you my email address, which is T as in Tom and my last name, FASSIEUX @cahealthadvocates.org. But sign up for our newsletter and you'll be able to get, you know, we'll definitely pay attention. Thank you.
And then Tatiana, just to reiterate, that's for California related issues. Is
Correct.
there a comparable
Yes.
email address for SMP related issues outside of California?
Yes, as a matter of fact, on slide number 36, where it had the thank you, it has the website, excuse me, the website for smpresource.org/contact us.
Here we go. Thank you.
You're welcome.
Matt, any additional lines of inquiry or comments?
Again, lots of comments. I could go all afternoon with comments, which I'm happy to print out for our presenters after this. A couple fabulous ones. My mother was told to tear up her Medicare card because it was no longer needed once she got on her MA plan.
Oh my gosh.
That might be my favorite comment. That was from Mary. Thank you for that. I think, oh, actually, we have a factual question if we can rewind a little bit. Michelle wanted to know, at the top of the call, you mentioned that this January through March enrollment period is only for MA-ish plans. Can you explain a little more about that?
Sure.
If a person had Medi-Cal and a Part D plan, could they change their enrollment, for example?
Short answer, no. Let me just be clear. The Medicare enrollment periods are not fair. They are not equitable. They don't provide the same rights to people in Medicare Advantage as they do with people in standalone Part D plans. The Medicare Advantage open enrollment period is a period from January 1st to the end of March every year, during which, if you begin the year enrolled in an MA plan, you can switch to another Medicare Advantage plan, or you can get out of Medicare Advantage, go back to traditional Medicare, and pick up a standalone Part D plan. What you cannot do is, if you're in traditional Medicare with the Part D plan, change to another Part D plan. It makes no sense, but this was a change in the law a few years ago. It's our understanding it was something that was pushed by some agent and broker associations in order in part to extend the selling season. So if you're in a Medicare Advantage plan and you don't like it, you do have an opportunity to change plans or get out. But note that if you are going back to traditional Medicare, as I think both Tatiana and Kathy mentioned, you might not have a right to purchase a Medigap policy. Medicare supplemental insurance policy is largely dependent upon where you live, the state you are in, and whether or not you can afford the premiums for a Medigap.
And if I could add to that too, David, Medicare does have two trial rights. One trial right one is when you're first at age 65 enrolled in a Medicare Advantage plan, you have 12 months to be able to get out of it and get a guarantee issue Medigap. Whereas trial right two is for somebody that gave up their Medicare supplement later on in their life with Medicare to enroll in a Medicare Advantage plan, and they had never been enrolled before in a Medicare Advantage plan. They have also a trial right. And the local SHIP can help further explain, and I believe it's also described in the Medicare Annual Handbook. And if I may promote the SHIPs, on the back of the Medicare Annual Handbook is the phone number for the local SHIP.
Thank you, Tatiana.
I think that's a great note to end on. Let me report one more comment, which was actually it's sort of an amalgam of a couple comments, which was, instead of spending money to advertise private Medicare plans, why don't we spend that money to advertise for the SHIPs?
So true.
I think you will find little disagreement with that sentiment. We want to thank you again for participating today, for participating ahead of time, for those of you that did send in your comments. Here again is the email address if you want to share additional comments, and we hope you understand that we do review them, and as noted earlier, we do take account for them as part of our advocacy efforts to try to change policy to make things better for Medicare beneficiaries. Also, on the rest of these slides are some additional resources, including previous webinars that we've done that get into more detail about a range of issues, including how people make their decisions to enroll in plans, trade-offs between Medicare Advantage and traditional Medicare, a more detailed summary of the new marketing rules, choosing between Medicare and Medicare Advantage, and then how to sign up for our weekly alerts. Thank you, Tatiana. Thank you, Kathy. Thank you, Kata. And thank you, Matt. And again, thanks to all of you for attending and sticking around quite a few minutes after we intended to close.
Yeah, thanks to the attendees and our presenters for sticking around a little bit late. We really appreciate that. Thanks to California Health Advocates Senior Medicare Patrol for their support of this presentation. And stay tuned for info on our next upcoming webinar, which is going to be February 22nd at 2 o'clock, I believe. And we're going to discuss Medicare hospice coverage, which, as we noted today, is yet another source of confusion. So be on the lookout for that. Thank you all, and I will now conclude today's presentation.